Welcome back. We are continuing to talk about the respiratory system and disorders of the respiratory system. And in this video, we're going to start out talking about other lower respiratory tract infections, such as an abscess. So, an abscess is a complication that can arise from things like very severe pneumonia. And abscesses occur because tissue dies due to bacteria, or it could be something like aspiration of something entering into the lungs, and the immune system says, oh, no, I don't think you're supposed to be here. And so there's a huge immune response that occurs, and this leads to formation of pus within the lung. So in this picture here, it shows you abscesses in the lungs, and you can see especially here that pus formation that occurs, and this is a type of liquefactive necrosis that's actually happening in the lung. And same thing here and here, you have the abscesses that have happened in the lung. This shows you a closer view of the neutrophil and the macrophage that move into the lung to combat that bacteria or whatever may be in the lung. And instead, that immune response creates this excessive amount of pus that leads to breakdown of the lung tissue. So some of the organisms that are commonly going to lead to a lung abscess would be like Staphylococcus, Streptococcus, other gram-negative or anaerobes, and then different types of infection, as well as things like cancer or an embolism that may occur in the lung. Now, symptoms would be a productive cough, fever, hypoxia, of course, from this, leading to clubbing of the fingers. Complications would be that it spreads systemically and with this infection, and then you could have a septicemia that's occurring. So remember, clubbing of the fingers, this is something that we see in different diseases that cause hypoxia, and instead of having the normal angle here, you have an inverted angle, and the fingers look very much like this. Another lower respiratory tract infection would be pulmonary tuberculosis, and there's about 1.7 billion people who are infected with this worldwide. About 11,000 new cases of TB in the United States alone every year. This is caused by Mycobacterium tuberculosis, this bacteria, and it's aerobic. So it likes to live in the apex of the lungs compared to the base of the lungs because there's more oxygen there. And this bacteria infects the alveoli. And so it is very easy to transmit tuberculosis through inhalation of infected droplets. But now, tuberculosis, we know, is something that goes into the lungs, but it can spread, and it can go to the brains, joints, liver, spine, kidneys, even into the bones. And this is just showing you a picture of that bacteria. As a matter of fact, it stains red when you're testing for it. So some of the risk factors for TB, we can call this TB risk. And so you have tight living quarters, some people who are below or at the poverty line, refugees or immigrants also, because a lot of these individuals are bringing tuberculosis with them into the United States. The immune system has some other type of issue, some kind of immunosuppressive thing, for instance, like HIV. Substance abusers are also very susceptible to tuberculosis, and then kids under the age of 5 years. Three possible routes for the infection. First you have elimination, you have retention, and you have active. So elimination means I get tuberculosis, but I don't really get the disease. What happens is my immune system is able to fight this off, and it rids my body of the disease or eliminates the disease. Retention is where the immune system is able to suppress the infection, and I have what we call latent tuberculosis. Reactivation can occur later on. Then there's active, and this is where the tuberculosis gets into the system. It evades our immune response and becomes active. The pathophysiology of primary tuberculosis. So we know the mycobacteria enters our alveoli. And then what's going to happen is we're going to have an immune response. And the first responders are going to be the macrophage. Now, macrophage, what they're going to do is they're going to do some phagocytosis. And typically when a macrophage phagocytizes something, it's going to send that something to the lysosome. Well, with tuberculosis, this ability to send the bacteria to the lysosome, it totally breaks down. And so the macrophage are not able to destroy this bacteria. And so now the bacteria absolutely replicates inside the phagocyte. Now, cell-mediated immunity can kick in, and the immune cells start to surround this macrophage where the infection is located, and we form what's referred to as a granuloma. Now, there's going to be necrosis of this tissue occurring at the site of this granuloma, and this is what we call a gone focus. Now, if the infection travels to a nearby lymph node, we call this a gone complex, and this can lead to caseous necrosis within the lungs. And we talked in our first videos about necrosis, and you know the word caseous means kind of cheesy looking, and so these gone complexes kind of have that cheesy look to them. And you can see this is a gone complex here. Now, latent versus active tuberculosis. With latent tuberculosis, the TB lives, but it doesn't grow in the body. It doesn't make the person feel sick or have symptoms. It also can't spread from person to person. However, it can reactivate. It can become active TB. So with active TB, the bacteria is growing in the body, and the person becomes sick, they have symptoms, and now it's communicable. So they can sneeze or cough on someone else, and it can be spread throughout the community, and for that individual, it can cause death. Signs and symptoms of tuberculosis: coughing that lasts for 3 or more weeks, coughing up blood, night sweats, fever, fatigue, unintentional weight loss, loss of appetite, and chest pain while breathing or coughing. So treatment for tuberculosis is a long treatment. So first of all, for the first 2 months, typically we treat with 4 different types of drugs, and after that, we will treat for the next, usually 10 months, with 2 of these medications to clear the tuberculosis out of the person. One of the forms of tuberculosis we've been talking about is human tuberculosis, and this is tuberculosis hominis. It's the airborne infection by droplets. It's harbored in the respiratory system, and we already talked about you can get this by spreading the disease in crowded, confined conditions. But there's also bovine tuberculosis, which is what I want to talk about right now, and this can be acquired by drinking milk from infected cows. So initially it affects the gastrointestinal tract, and then it's able to move through the body. However, this has been eradicated in North America and other developing countries. And a couple of things that we've done to make sure that you can't get TB from milk is that all the cows are tested for tuberculosis, and that's a pretty routine type of testing that has to be done in the United States. And then also milk has been pasteurized for years. However, you don't need to pasteurize the milk if you've tested your cow and you know that your cow doesn't have tuberculosis. So you won't have tuberculosis in the milk itself. So this is just showing you some of the granulomas, those little white spots that form with tuberculosis. And then also these GON complexes with the caseous necrosis that can form as well. And you can see the damage that this mycobacterium can cause to the lungs. Now, in order to test for tuberculosis, we have the positive tuberculin skin test. And this is where we are looking for a cell-mediated immune response. And if you get this response, then it tells you that the individual has the tuberculosis. So the person is actually injected with some of the tuberculin, and then we look for this red spot, this induration is what we really call it, and we look to see how big the spot is to tell us how much of a response the person has had. Which of the following involves infection of the entire respiratory tract? The common cold, pneumonia, tuberculosis, or cancer? What do you think? And the answer is pneumonia. Pneumonia can involve all respiratory tissue and, due to its virulence, is a major health risk. All right, so we're going to talk about chronic obstructive diseases, and this would include asthma, bronchitis, emphysema, bronchiectasis, and then things like pulmonary fibrosis. So asthma, this is chronic inflammation of the airways leading to bronchial constriction. And symptoms would include wheezing, breathlessness, tight chest, a cough. The hallmark is that it's intermittent. It's reversible airway obstruction. It does have chronic inflammation, and the person has increased mucus in this disease. So there's two types we're going to talk about, atopic versus non-atopic. And the first one, this is what we call an extrinsic asthma, and that it's the most common type, and basically what that means is something from the outside world, like an inhaled antigen, causes the asthmatic attack. So that attack is inflammation mediated by the IgE antibody production. Non-atopic asthma is an intrinsic asthma. We don't understand this as much. It's not as common, but it's not from an inhaled antigen. So it's not like the person has allergies and it creates an asthma attack. So with asthma, this is an exaggerated hypersensitivity response to stimuli. So airway inflammation is going to create, is going to be created by these inflammatory cells. So your mast cells, your eosinophils, lymphocytes, and then eventually what it's going to do is it's going to damage the bronchial epithelium. So the triad of asthma includes airflow obstruction, bronchohyperresponsiveness, and inflammation. So we'll talk about each of those as we go along, and we're going to start out by talking about the formation of this mucus plug. So if you look at the normal bronchioles, so this is a very thin layer of mucus. And then here is the stratified columnar epithelium, and underneath that, the basement membrane. Then we have what's called the lamina propria. And in the lamina propria, we have a few macrophage floating around, which is totally normal. And then we also have in here a few goblet cells, and those are totally normal, helping to make mucus. However, in someone who has asthma, you can see there's a huge difference in these layers. So first of all, there's a whole bunch of mucus that's being formed because there are a lot of goblet cells that are formed in this epithelial layer. Also, in this mucus layer, you see some eosinophils. Now, those eosinophils are going to be important. We'll talk about what they do later on. A lot more macrophage in here, which is going to attract other lymphocytes and neutrophils, as well as eosinophils and mast cells to this area. And then you can see there are many more glands in this area as well, so that the thickness of the bronchial wall is tremendous, but there's also this mucus plug that's forming. So players in the asthma response are, one, the IgE antibodies, and they have the ability to form a complex with mast cells, causing those mast cells to release histamine. And if you remember, histamine is a trigger for this inflammatory response. One of the other things that happens is lymphocytes are drawn to the area. And you have two types of helper cells. You have a T helper cell 1 and a T helper cell 2. And the T helper cell 1 is normally found in the lungs, not so much the T helper cell 2. But with asthmatics, you find a whole bunch more of these cells in the bronchioles. Now, the T helper cell 1, they're helping to promote inflammation, where the 2 increase the humoral response. So remember, we talked about extrinsic or atopic asthma, and this is initiated by that type 1 hypersensitivity reaction when someone is exposed to an extrinsic antigen or allergen. So this allergen is going to help to cause an increase in the mast cells and their binding to the IgE, which then causes the histamine secretion. The histamine increases inflammation of the airways, and so that's what you see in this picture here. You have some kind of antigen like pollen, and that's attaching to a dendritic cell. That dendritic cell is then helping to stimulate the T helper 2 cells. They're releasing interleukins. Those interleukins, like interleukin 4, is going to cause IgE secretion, and that IgE is going to bind to mast cells. And we know the mast cell then degranulates, and we have histamine release. We also have interleukin 5, which is going to cause recruitment of eosinophils, and they also release their granules, and this helps to mediate the asthma attack. Another thing that we see is the increase in mucus production. So you have these antigens, and these antigens are binding, and they are stimulating the mast cells, the eosinophils, and the type 2 cells. And so what these do is these increase inflammation. They also increase the mucus production. The intrinsic or non-atopic response, this is triggered by something that is not an allergen. So it could be respiratory tract infections, exercise, hyperventilation, getting cold, emotional, even gastroesophageal reflux can do this. And this can lead to epithelial damage, leading to IgE production. And as we just talked about that IgE production can increase mucus. It can also cause bronchospasms and lead to inflammation. So with asthma, you have an increased respiratory rate with prolonged expiration, which it sounds like this wheezing that's going on. The person has shortness of breath and a dry cough, plus fatigue and dyspnea. And this is just showing you again that interaction with some kind of pathogen. It could be inhaled or it could be internal. Your mast cells and degranulation to cause that histamine, the bronchoconstriction, and the hypersecretion of mucus and edema. And now it's more difficult for the patient to get air out than even air in. So this is showing you these mucus plugs. And these close up the bronchioles. And this is a huge mucus plug that you can see. And of course, air isn't able to get in or out when the plug is so thick. Chronic bronchitis is another chronic obstructive disease, and this is airway obstruction of the major and the small airways, and is most common in middle-aged men, caused associated with irritation from smoking, pollution, recurrent infections, and clinical diagnosis requires a history of chronic productive cough for at least 3 consecutive months in at least 2 consecutive years. So the pathogenesis of this chronic bronchitis is hypersecretion of mucus. So we have an increase in the number and the size of goblet cells. So now you get these chronic viral and bacterial infections, but what happens is they're not actually initiating the chronic bronchitis. The bronchitis is basically initiating these infections, you might say. So what's happening is you have all this buildup of mucus, and this mucus is a fantastic place for these viruses and bacteria to live. And so the bronchitis is creating the infection. And so you can see this is a section of bronchitis, and the mucus glands are ginormous. They're way larger than they're supposed to be because they're hypersecreting mucus. So due to the increased mucus, there's a mismatch between ventilation and perfusion. So blood is flowing fine, but you can't get the oxygen in or even the carbon dioxide out. So you have hypoxemia and you have cyanosis going on, which leads to shortness of breath, and the person has a decrease in exercise tolerance as well. So their breathing is labored at rest as time progresses, and they get this respiratory wheezing, and you can hear crackling or crackles on their chest, and they can't maintain their normal blood gases. So all of this is going to cause polycythemia, and polycythemia being excess production of red blood cells in order to try to increase oxygen in the blood. And then we have pulmonary hypertension that also can occur from this. And then right-sided heart failure due to the pulmonary hypertension with peripheral edema. And that right-sided heart failure due to pulmonary hypertension, if you remember, we call that cor pulmonae. And sometimes when you see this problem, they call them blue bloaters. So you can see on the left, this is normal bronchial tissue, and on the right, this is abnormal. So you can see an increase in the thickness. These are glands and all in here with mucus. This is even a mucus plug right here. Emphysema, characterized by destruction and enlargement of air spaces, which would be our alveoli. Also, there's going to be a loss of lung elasticity. Remember, there's a lot of stretchiness to those lungs so that they can fill up like balloons, and that stretchiness over time is going to disappear. an abnormal enlargement of our alveoli distal to the terminal bronchioles, which we will also have destruction of the alveolar walls and capillary beds. There's going to be enlargement of the alveolar spaces, leading to hyperinflation of the lungs and an increase in total lung capacity. So this is associated with long-standing cigarette smoking. That's the predominant reason for emphysema, and it usually involves the upper half of the lungs. Now, I will tell you that the lungs don't like what we would call particulate matter. They don't like a lot of dusty stuff. And that's what cigarette smoking is doing. It's introducing all of this particulate matter to the lungs. But there are other ways to get emphysema over time. And, for instance, you could be outside in a dust storm and you do this over and over and over again and you inhale all that fine dust. You can cause emphysema in your lungs as well. So two major causes of emphysema, smoking and alpha-1 antitrypsin deficiency. When we talk about tobacco smoke, this increases the number of neutrophils and macrophage in the lung, and then it promotes neutrophil degranulation. So with emphysema, what we see is a breakdown of those elastin fibers along with the walls of the alveoli, and this is because these neutrophils release an enzyme or multiple enzymes which are called protease enzymes. And protease enzymes are able to break down different proteins. So for instance, the elastinase enzyme helps to break down elastin fibers by these neutrophils. So this alpha-1 antitrypsin is an antiprotease enzyme that can protect the lungs from breakdown. And smoking stimulates inflammatory cells to move into the lungs, and the alpha-1 antitrypsin may not be enough to fight off all the neutrophil that have moved into the lungs because of this increase in particulate matter. So you have smoking, or you have this alpha-1 antitrypsin deficiency, and then that leads to this inflammatory response. So you have proteases that are going to degrade the elastin and degrade the alveoli. You also have some epithelial cells that go through apoptosis and necrosis, and then mesenchymal cells will also go through apoptosis. So there's a decreased ability for the lungs to repair and for contraction and matrix synthesis and things like that to happen. So here are normal alveoli in the lungs, and then these are alveoli with early emphysema, and you can see where there's been dramatic breakdown of these alveoli. So two types of emphysema. One is called centroacinar or centrolobular emphysema, and then there's panacinar. With centroacinar emphysema, this usually is worse in the upper lobes of the lungs. It affects the bronchioles in the central part of the respiratory lobule. So if you imagine a bronchiole with all of the alveoli around it, like a cluster of grapes, it's affecting the bronchiole mostly. It usually preserves the alveolar ducts and the sacs, and this is the number one cause by smoking. Now, by the way, those alveolar sacs can and will break down over time. So this is a picture of centrolobular emphysema and what we have called dirty holes. And this is from smoking, and this is a buildup of tar and different products that we find in cigarettes. So you can see a picture of normal lung tissue, and look at the little bronchioles. And then this is central or centroacinar emphysema, and you can see definite changes in those bronchioles. With pan-acinar emphysema, this destroys the entire alveolus, and it's usually in the lower half of the lungs, mainly observed in patients who have that alpha-1 antitrypsin deficiency. But keep in mind that smokers can have pan-acinar and central or centroacinar emphysema. So this is showing you a normal acinus, and that includes the respiratory bronchioles and the alveolar duct and the alveolar sacs. And then with centroacinar emphysema, you see that the alveolar sacs are spared, but the respiratory bronchioles are not. With pan-acinar, the alveolar duct and the alveolar sacs are not spared. And again, same thing here. This is normal lung tissue, and then you have the centroacinar and the pan-acinar, which is taking up more of the alveoli and destruction of that alveoli. And obviously you can see why people who have this disease don't survive. Persons have marked dyspnea with emphysema. They struggle to maintain normal blood gases, and you'll see increased ventilatory effort, but they have what's called a barrel chest, and that's because of air trapping. Okay, so go back to your physiology just a little bit, and if you remember, again, the lungs are full of elastic connective tissue in the healthy state. And when we inhale, it's all about using the respiratory muscles to stretch that lung tissue out so that the volume of the lungs increase. And when the volume of the lungs increase, the pressure inside the lungs decreases. Now the pressure in the atmosphere is higher than the pressure in the lungs, so air is going to move from high pressure in the atmosphere to lower pressure in the lungs. You're going to inhale. In order to exhale, however, what's going to happen is we're going to have to squish those lungs. We're going to have to squeeze them like we were squeezing a balloon to squirt the water out of that balloon. And so what happens is the lungs, once they fill up with air, they're going to snap back. They're going to recoil because of all of the elastic connective tissue. So think about stretching a rubber band and then just letting that rubber band go. The rubber band recoils. And so after you're done inhaling, the respiratory muscles relax, and it's like it let the rubber band of the lungs go, and the lungs snap back or recoil back, and they push on that air that's inside the lungs. And now there's a higher pressure in the lungs than in the atmosphere, and so you exhale. But what happens if I have emphysema and I don't have that elastic connective tissue anymore? I'm not able to snap those lungs back like I would snap back a rubber band. And if you can't bring those lungs back to their smaller size, they're not going to be able to exhale air. It's like fill up a water balloon, but you don't have the strength in your hands to squeeze that water balloon to push all the water out of it. Instead, the water balloon just stays filled with water. Well, your lungs just stay filled with air. And so that's what we call air trapping. Well, if they're filled with air all the time, then your ribs and your muscles are going to change shape in order to accommodate those lungs, and you get a barrel chest. And the person has a very difficult time exhaling. And people in end stages of emphysema, they have such a difficult time. You could put a match right up to their lips and they couldn't blow the fire out. So expiration occurs through very pursed lips, and so sometimes they're referred to as pink puffers. And you can see the air sacs where all of this air is trapped inside those lungs. So as this disease advances, you're going to see a drop in the partial pressure of oxygen in the arteries, which leads to that dyspnea, increased respiratory rate, pulmonary vasoconstriction is going to occur, and then that leads to pulmonary hypertension and cor pulmonale. And you can just see the pulmonary hypertension. Bronchiectasis, bronchi meaning bronchioles, and then ectasis is expansion. So the bronchioles are damaged and they're dilated. So this occurs due to some kind of an obstruction. It can be bacterial or just something gets stuck in the airways, and then you have inflammation that can cause a mucus plug to obstruct those airways. So this tends to be localized in neoplasms and with aspirated foreign bodies that block just a portion of the airways. Whereas widespread bronchiectasis is typical for patients with things like cystic fibrosis or sarcoidosis who have recurrent infections and obstruction of airways by mucus throughout the lungs. Immune cells and their cytokines can cause the bronchioles to become dilated. There's a loss of elastin and a buildup of collagen. The lungs are not as compliant or stretchy anymore, and the patient has recurrent infections because these bronchioles are dilated and there's stasis in the airways. So the air is not moving, things are not moving like they're supposed to. So now you have widespread hypoxia, which leads to widespread vasoconstriction. That causes increased vascular resistance. And of course, anytime you have increased resistance, then pulmonary hypertension or any type of hypertension, but in this case, pulmonary hypertension goes up. And you have right ventricular hypertrophy, which then leads or is cor pulmonale. Symptoms are wheezing and coughing, it comes and goes, shortness of breath, foul-smelling mucus, long-term hypoxia, which also leads to digital clubbing. This shows you a picture of the dilated bronchioles here, and then even right here, which of course leads to that recurrent infection. Also dilated bronchioles. Cystic fibrosis is a genetic disorder that affects the lungs. It also affects the pancreas. So cystic means you have these fluid-filled sacs, and fibrosis is where there's excess fibers in an organ. This is an autosomal recessive disorder that affects the CFTR gene, and you need to inherit this from both mom and dad. So if you only inherit from mom or you only inherit from dad, then you're considered a carrier of this disorder. So the CFTR stands for Cystic Fibrosis Transmembrane Conductance Regulator. It's a big one. So it codes for the CFTR protein, and of course this disorder is more common in people of European descent. The CFTR protein is a channel protein, and it pumps chloride ions out of a cell and into various secretions. These chloride ions help to draw water into that secretion, and it helps to thin the secretion out. So imagine the secretion is mucus. Instead of having this thick, gooey, strong mucus, you have this more thin, watery type of mucus when chloride ions are added to that. So you can see this is the CFTR protein, and it is actively transporting chloride ions out of the cell into this mucus layer. So if you don't have the CFTR protein, you can't pump the chloride ions into the mucus, which also means that water isn't drawn into the mucus and the secretions are now super thick. Now in early childhood, pancreatic insufficiency is the prominent effect of cystic fibrosis. Now remember, these chloride pumps are not just in the lungs. The pancreas has these pumps as well. And this now thickened mucus jams up the pancreatic ducts, and the pancreas can't release its digestive enzymes into the small intestine for fat digestion and then absorption of that fat. So this leads to poor weight gain and failure to thrive. And the pancreas is then eventually damaged because these digestive enzymes back up into the pancreas, and the person ends up with pancreatitis. But you can also end up with insulin-dependent diabetes once the pancreas does not function any longer. Later in childhood, lung issues do start to arise. Bacteria love to live in that thick, ooey gooey, sticky mucus. And since you can't move that mucus out, so the cilia are important in moving all this mucus up and out of the lungs, and then we swallow that and it's destroyed in the stomach. Instead, what's happening is you don't have this mucus elevator anymore, and so the mucus gets stuck, and those bacteria get stuck in there and they grow. And so one of the things that can happen is your patient gets pneumonia. The bacteria can also form something that is pretty amazing. It's called biofilm, and it's this filmy coating that can go over top of the bacteria, and it prevents our immune system or even antibiotics from being able to get to this bacteria and destroy it. And that's cool for the bacteria, but not so cool for us. So this all can lead to bronchiectasis, which we already talked about, and we can have hemoptysis from this, and then eventually respiratory failure, which is the leading cause of death. And this shows you what's called a honeycomb lung, and this is from that fibrosis of the lungs from the cystic fibrosis.